Hi friends, this is Dr. Venkatesh, and is anterior optic capture a viable option when you have a broken haptic? Let's follow this case. I'm performing the capsular rhexis. Please note the size and the centration of the capsular rhexis. The rhexis should be as well centered as possible, reasonably round, and it should be just less than 5 millimeters. Lens turns out to be soft, and I'm going to use my soft chop technique in order to remove this nucleus. You need to follow two important principles in order to successfully perform the soft chop technique. First is, while burying the phaco tip inside the nucleus, use pulse mode, power of just 20 and a low vacuum of 100. And once the phaco tip has impaled the nucleus, keep the power at 0, increase the vacuum to 250 to 300. This will give you an excellent hold and help you to chop the soft lens. The second important point that you have to note is that you have to bury the phaco handpiece horizontally into the nucleus substance, and this should be just beneath the surface of the lens, what I call the snorkel chop. If you employ these techniques, you can safely and reliably chop even a very soft cataract. The cortical aspiration is done very carefully, and doing a good cortical cleavage hydrodissection in the beginning will ensure that you leave the capsular bag completely empty of all cortex. Leaving no cortex behind will also discourage the formation of posterior capsular opacification. In this case, there are 2 points that you can note. Firstly, the size of the pupil is about 5 millimeters in this case, and the rhexis is just a shade smaller, maybe less than 5 millimeters, say 4.75 millimeters. This is important in order to understand what's going to follow. Also, you see that the rhexis is quite well centered. When I implant this foldable indigenous intraocular lens, I note that the disaster has happened in loading this lens, and the trailing haptic is truncated close to the optic. Leaving this lens behind in the bag is definitely going to cause it to decenter. Since I did not have a backup power for this intraocular lens, explanting the lens would be the option, but this will leave the patient aphakic. Leaving the IOL behind will cause it to decenter. Is there a way to achieve stable centration of this lens? So I tried to attempt an anterior optic capture. Just see how the anterior optic capture is accomplished in this case. The lens is first put inside the capsular bag. The viscoelastic is aspirated. The optic is then tilted with the Sinskey hook and brought out of the capsular bag. The other end of the optic is then lifted with the Sinskey hook and brought out of the capsular bag. Since I pulled out the coaxial IA by mistake, the chamber collapsed, so I'm going to attempt it again. The other end of the optic is then lifted and you get a good optic capture. This is noted by seeing the squaring of the edge of the capsular rhexis, which is very obvious in this case. Now let's take a few discussions. The cut haptic will be in the bag. It will not hurt the surrounding tissue. The optic gets captured in the rhexis and will remain centered and quite stable. However, the rhexis size should not be more than 5 mm and should be approximately round and well centered. If you have a larger rhexis, it will lead to spontaneous optic release in the post-op period. Although there is a higher risk of PCO, good cortical aspiration and good cortical cleavage hydrodissection will reduce it. The patient was explained that the haptic was broken, but I achieved an alternate fixation, and the patient accepted this because he had a good post-operative visual acuity of 6x6 with just a -0.5 cylinder. And you can see the squaring of the rhexis edge in this case and a beautifully centered optic. This could be one option provided all the prerequisites are met with when you have a truncated haptic. Thank you for your attention.